Are you my moderator? Okay, thank you all very much for being here. I know it's a beautiful Friday, and I'm the last speaker. It's my absolute pleasure and honor to speak about the subject that I find extremely important to both clinicians and to patients, and very underrepresented in primary care meetings. So I'm so glad that we're going to be talking about this. My name is Sharon Parrish. I'm an internal medicine physician. I work in behavioral health and women's health. But for this audience to know, I worked in general medicine and primary care for over 25 years or longer, and I still consider myself a primary care physician. And I approach these discussions and thinking about these issues and this information from that viewpoint. Okay, am I going to see them, or is the moderator? Because I thought the moderator was going to read them. Thank you. Okay. Oh. I thought it wasn't for me. Shall I give it to you? We'll get it straight. Hi, thanks so much. I'm happy to do it, but I didn't think it was for me. So, shall we get going? Okay. And these slides advance with this. Here you go. Okay, and the faculty chair, I'd like to acknowledge Dr. Joanne Pinkerton, who's a professor of obstetrics and gynecology and the division director of midlife health in the University of Virginia. And I actually know her personally, and I highly respect and regard her work. And I'm glad that she was the chair who oversaw the development of these slides. The disclosures are reported on this slide. My disclosures are listed, as are Dr. Pinkerton's. Okay, the learning objectives for this session are to differentiate key aspects of the pathophysiology, clinical manifestations, and the burden of vasomotor symptoms in menopause, to analyze the most recent evidence on the latest hormonal and non-hormonal therapies for menopausal vasomotor symptoms, and to support patient understanding of these associated benefits and risks. We're going to customize counseling in our discussion, the approaches that are based on individual patient profiles, and facilitate personalized discussions regarding the management and treatment decisions for vasomotor symptoms during menopause. Let's start with the first polling question.
Yeah, here we go with questions, guys. Get ready, we're almost done. For those providing patient care, how many of your patients experiencing menopause report disruptive vasomotor symptoms in a typical week? So think about your patients in 1 week. A, 1 to 2, B, 3 to 5, C, 6 to 10, D, 11 to 15, E, greater than 15, or F, not applicable.
Okay, so the choice, number one choice answer was 1 to 2. And those, let's look at that information. Moving on to the discussion about this. Oh, sorry, hang on. Let's go back. Okay, the pretest questions.
Okay, so you know you guys are going to see these questions again. Which of the following is true of the burdens of menopause-associated vasomotor symptoms on patients? A, greater than 50% of patients report hot flashes as almost unbearable. B, hot flashes persist for a median of 3 years from menopause onset. C, VMS episodes peak during premenopausal phase. D, VMS is associated with increased risk of cardiovascular disease. Do your best here.
Are we going to see responses on this? Okay, and so the number one choice was hot flashes persist for a median of 3 years from menopause onset. Okay, pretest question 2.
In which of these clinical scenarios would, I'm going to ask you to pronounce it correctly.
We practiced this beforehand because it's a hard drug to say. Fezolinetant.
Be the preferred treatment option for a patient in menopause with moderate VMS. A 55-year-old patient with CKD and a creatinine clearance of 25. B, a 53-year-old patient with atrial fibrillation who takes amiodarone. C, a 62-year-old patient with a family history of breast cancer, or D, a 65-year-old patient with treated HCV and cirrhosis?
And the prime choice here was the 62-year-old with a family history of breast cancer. We'll look at that too. Okay, pretest question 3.
Almost done here, guys. A 58-year-old healthy woman with onset of menopause 5 years ago presents for treatment of severe vasomotor symptoms. How would you counsel her on treatment options? A, based on her age and the onset of menopause, treatment is not indicated. B, she is a candidate for hormonal therapy only. C, she is a candidate for non-hormonal therapy only. Or D, she is a candidate for either hormonal or non-hormonal therapy.
Okay, and the prime choice here was that she's a candidate for either one. Okay. A lot of good baseline knowledge. Okay, let's start by looking at the overview of vasomotor symptoms, the role of primary care physicians or primary care providers in optimizing care. So here's Janice. She's 47. Last menstrual period was 8 months ago, having moderate to severe hot flashes, worse at night, and significantly having these hot flashes impact her sleep. She says things like, I can't sleep. I'm always exhausted. I'm so nervous, I'll have hot flashes in the middle of a work meeting and not be able to function. I'll add that in. My anxiety is through the roof. I really need help. So these are her key symptoms: exhaustion, nervous about her hot flashes, and having the hot flashes, and a lot of anxiety, and she feels distressed such that she wants your help. Poll number 2.
What additional history or physical exam information would be helpful in assessing Janice? And we're throwing one at you here because you can select all that you think apply. So A is additional menstruation history, B, environmental and lifestyle information, C, historical sleep efficacy, D, a hormone panel, or E, her mental health history. Remember, you can choose more than one.
So people chose most of the options. Hormonal panel was the least likely to be chosen, although still thought to be potentially helpful.
We want all the information.
Right. Although we'll talk about hormonal panels and how to use that. So the symptoms of menopause, some of which Janice is talking about, 50 to 82% of people in the United States undergoing natural menopause, and those would be people of female birth gender, experience severe vasomotor symptoms, and heretofore we'll call it VMS. Episodes peak at 1 year after the final menstrual period, although you don't know that's the final one until you hit a year. The median duration would be 7.4 years on research, looking at in research. Only 10 or 10 to 20%, it's not only, 10 to 20% of those who experience vasomotor symptoms find them almost unbearable. And they may, in fact, these VMS symptoms may, in fact, persist for greater than 15 years for about the same percentage of patients, 10 to 15. So often the first noted symptom is a change in the menstrual cycle length. It might be heavier, it might be more spread out, it might be irregular. Then hot flashes are the one that's most commonly reported as being distressing or impairing or interfering. Sleep problems, mood changes such as irritability and depression, memory, vaginal health and sexuality. That's sometimes noted later, although not always. And this may be paired with issues around bladder control, urinary symptoms, recurrent UTIs, weight gain, perceived loss of muscle mass or strength, joint pain, and headaches, and sometimes fatigue, which isn't on the slide, but it's associated with kind of some of the other stuff like sleep problems. So what is the burden of VMS, particularly related to menopausal symptoms? And you'll see that you can see the most in a particular trial, Participants reported issues such as sleep, self-care, work, mood, emotions. These were things that were affected by VMS. So again, we're looking at things that are affected by VMS. So sleep, self-care, work, mood, emotions, relationships, being able to concentrate, because they come as perhaps you're working on something or delivering a presentation and they come suddenly, they interfere, or your sleep is disrupted and therefore secondarily you have trouble with concentration. Maybe there's concern about social activity, sweating in a favorite outfit, and just overall daily health and physical health and daily activity. And in terms of the actual symptoms, beyond the burden of VMS, hot flashes are the most commonly reported. You can see over 90%. And then a variety of things are about half of the individual. Sleep, vaginal dryness, mood changes, libido changes, and dyspareunia about a third. Slow weight gain, irregular periods, vaginal atrophy, dry thinning hair. I suspect that some of the things that are less frequently reported according to the slide have to do with the time since menopause or in the transitional time that people are surveyed. Because some of these other things become more prominent over time, like vaginal atrophy sets in and becomes worse over time, thinning hair. And so maybe they're not surveying in these surveys women who are in the latter ages or latter stages of postmenopause. But they're important problems, and if your patient tells you about it, you want to acknowledge it and understand its place in their menopausal transition. So, what are the physiologic changes, and what kind of clinical timeline do we see? So it's difficult to classify women according to perimenopause. This difficulty, because it's not always easy and clear, because people don't fit into good, like really little tiny boxes. Sometimes things cross over and they look like they're in a variety of stages. But that's contributed to fewer studies in the perimenopause. And the cardiometabolic changes that occur during early perimenopause are really not well understood. And I think what we're learning is that things start earlier than we suspect. Although the cardiovascular issues we'll see a bit later really set in after the final menstrual period is really over for some time, or certainly a year. So early, we see changes in estrogen and hormones, and FSH can go up. And we may see that the early intermediate markers for cardiovascular risk may change, such as CIMT and vascular remodeling, endothelial function, if it's measured, sometimes getting a carotid Doppler, things like that may show this. In late perimenopause, meaning not yet established postmenopause, there's no moment of menopause because you don't know until it's a year later that happened. But so we talk about late perimenopause and postmenopause. You can certainly see that E2 and the AMH hormone go down and FSH goes up. There's a change in body composition such that fat mass increases, particularly abdominal fat, and the lean muscle mass, I prefer that to fat-free, the lean muscle mass may go down if people don't weight train to compensate. And energy expenditure decreases, and things like fat oxidation, energy intake, and the utilization of energy change and metabolism. And so those issues about abdominal fat and weight gain are real. We start to see real changes of cardiovascular risk that are more sort of harder to intermediate to harder endpoints, such as dyslipidemia. Certainly within 1 year of menopause, people's LDL will be different than it was, and they're surprised. And some of these other vascular markers may change further. It's really hard to measure endothelial function, but people look at things like coronary calcium score, carotid intimal thickening, et cetera, and we try to estimate how that figures into risk. Insulin resistance may change, or someone's A1C may start to creep up and they're uncertain as to why, and that may be linked to the change in lean muscle mass, and certainly the sleep disturbance, which may be linked to vasomotor symptoms. Later on, we see persistence of the hormonal changes that I mentioned, enhancement or more pronouncement of the body composition changes, and energy expenditure changes, and a more pronounced ability to detect or note the cardiovascular risk factor issues. Now, these are risk factors. These aren't established coronary artery disease, but what we do know is that it's under-recognized that women can have cardiovascular events earlier than we expect them to. So women in their 50s and 60s, and sometimes it has to do with the stage of menopause and the co-occurrence of these things. And I think that we're really pushing into women's health to have earlier detection for intermediate markers that can lead us to detect before women have clinically relevant cardiovascular events. So what's a premature menopause? There's a number of terms that have been thrown around over time: premature menopause, primary ovarian failure, primary ovarian insufficiency, but we're going to use the term premature menopause. This may be due to a surgery for a variety of reasons, and usually would have to involve bilateral salpingo-oophorectomy. They may, when off like with cancer, usually it's early breast cancer. I've seen it, at least in my practice, from radiation or chemo, having to take a medication, usually a hormonal suppressant related to cancer treatment, or they just have what now is termed primary ovarian insufficiency, meaning there's no other reason for premature menopause that we triggered at exogenous. One of the take-home points, and as a primary care physician at heart, I really want to make sure I remember to tell you what I think it's important to remember, which is that this early menopause is not good for health, and we need to address it like a health condition and a health risk factor, and not be reluctant to treat aggressively to get people to the hormonal status that they would have been at if they had aged now at a natural age of menopause, especially if it's iatrogenic. So there is an increased risk of mortality, coronary heart disease, dementia, Parkinson's, osteoporosis, mood changes, and an elevated risk of something called genitourinary syndrome of menopause. And this is a newer term, if you haven't heard it before, for the clinical manifestations of vulvovaginal atrophy related to estrogen deficiency. So when you have tissue changes and dryness and pain with sexual activity or dyspareunia, or you have or urinary symptoms like urinary frequency, UTIs, stress incontinence, those things all collectively are called the genitourinary syndrome of menopause. And its short abbreviation is GSM. And I think it was also thought to be more in some studies looking at this term with patients. It was actually branded by the Menopause Society, formerly the North American Menopause Society. They felt patients thought it was more favorable than hearing you have vaginal atrophy, which really sounds gloomy. This is a syndrome. It's related to menopause, and we can treat it. And it may be associated with another problem, which is a diminished libido that causes clinically significant distress, called hypoactive sexual desire disorder. So I want to highlight the blue box, blue meaning not black, because black is ominous. Blue is just pay attention. Menopause secondary to BSO, bilateral salpingo-oophorectomy, is associated with more severe VMS, higher rates of mood and sleep, mood disturbance, mood disorder, sleep disturbance, joint symptoms, and sexual dysfunction. And definitely women experience having these things as having a lower quality of life than if they were to have a natural menopause. And it has to do with the abrupt nature of the discontinuation and also the complete nature. Women make small amounts of bioactive hormone if they have their ovaries in place throughout their life, even well into their 70s and 80s. And so they have less quickly and eternally. And we want to consider this in thinking about the risk associated with this. So there is an increased CVD incidence in postmenopausal women, as I started to mention, and even premenopausal women who are aged less than 40 to 54 years, compared to women, but women who are premenopausal who are less than 40 to 54 years who have early menopause would be similarly addressed by supplementing them to the age of natural menopause. We have less data on that premature menopause group in terms of cardiovascular risk. For example, this meta-analysis of over 200,000 women there were over 10,000 cardiovascular outcomes compared to those with and without menopausal symptoms. And one thing that we want to note is that vasomotor symptoms and their severity may be a marker for increased risk of cardiovascular disease or CHD, stroke, or CVD. So the cardiovascular disease incidence was 2 to 6 fourfold greater in postmenopausal women versus premenopausal women. And women who had were more inclined. And that's not shown in this stats. This is just the incidence, but that's a point I want to make. So those might be people you pay more careful attention to in your vascular risk screening. And you can see the differences in the risk compared to pre and postmenopausal women in the orange, or the postmenopausal women, and the relative risk, or this is incidence. So now, I think this is a very pretty slide, but it's complicated. And we could spend our brains trying to understand it or try to get to the gist of it. I think the point, people say, well, why do people have vasomotor symptoms? It's a disruption in thermoregulation. So during menopause, when your estrogen levels drop, we'll just talk English. That's what I say to my kids when they're trying to write things, my college kids, just write English. So we'll talk English instead of trying to make sense out of this fancy brain schema. During menopause, decreased estrogen leads to overstimulation of something called the KIND neurons. And this results in increase in NKB neurotransmitters and increased activity in the thermoregulatory center. So it's like an upregulation of these irritated or overstimulated KNDy neurons. And this results in some like a hypersensitivity to external cues also. So if you're in a little bit of a warm room or become a little anxious, you can flush a lot and sweat a lot when before that might not happen. And this triggering of heat dissipation is what happens to ward off feeling very warm. And there's actually true escalations in body temperature. There's some key parts of the brain and the hormonal system that are involved. So it's the preoptic area that receives the thermoregulatory information from a warm afferent pathway. So you feel warm, it sends messages to the preoptic area, or the MMPO. Then CNS centers controlling heat defense effectors cause you to sweat and shiver. And then there's also this upregulation of the KNDy neuron activity that then results in NKB release that also enhances this process. And this is all sort of a positive feedback loop the estrogen levels drop, and then the KNDy neurons upregulate, and then you enhance the activity of this whole thermoregulatory center. There's some involvement in the GnRH neuron, the anterior pituitary, and the ovary, and the result also results in the similar simultaneous processes of elevation of FSH and the drop in estradiol. What is the role of all of us as primary care providers in diagnosing and managing menopause? So this will affect approximately half of your patients who are genetically or born female. Healthcare providers or practitioners in primary care are frequently the first point of contact. And this is sometimes missed or misdiagnosed or misunderstood. We think they're anxious only. They may have an anxiety as part of their menopause, or that they have thyroid disease, and we rule that out, and then we forget that menopause in itself needs management. Now, hopefully you know your patients over time, and there's a foundation of trust that's already been established to support this type of education, teaching patients about it. And their partners, female and male partners of patients suffering with menopausal symptoms, there's research showing that they want to learn and understand too, so they can support their partner. Menopausal symptoms aspect, we already demonstrated that it affects many aspects of life. And there's a process, like there's premenopause, perimenopause, early perimenopause, late perimenopause, early postmenopause, later postmenopause. And so this is years to decades that we really need to think through the trajectory. So for example, we don't get into this so much today, but vaginal atrophy and the GSM symptoms associated with it can come later over time. And so while you've done with the hot flashes of somebody or the vasomotor symptoms, maybe later on that you need to screen or ask about dyspareunia. So there's a trajectory. Okay, let's go to post-test 1.
Okay, so which of the following is true of the burdens of menopause-associated VMS on patients? A, greater than 50% of patients report hot flashes as almost unbearable. B, hot flashes persist for a median of 3 years from menopause onset. C, VMS episodes peak during premenopausal phase. D, VMS is associated with an increased risk of cardiovascular disease.
Okay, and is predominantly the cardiovascular disease, and let's look at that. So yes, the rationale, the answer is presumably D, or supposed to be D, and the rationale is what we discussed about CVD, stroke, and CHD, and the time frame is 7.4 years, and median peak about 1 year after LMP, and that the severity, the highest severity is in about 10 to 20% of patients who say it's almost unbearable. Okay, now let's look at the current treatment landscape for menopausal VMS. So let's look at Janice in terms of treatment options. She's 47, moderate to severe hot flashes, worse at night, significantly impacting sleep. She reports, as we know, some mild anxiety. She also has occasional migraines, and she's up to date on her preventative health care and maintenance. She had a C-section ×2, but no other surgeries. Her ovaries in place. She's married. She's a non-smoker. She's moderately active, and she works a full week, 45 hours in marketing, and has no other clear medical conditions as manifested by lab tests or medications. Poll 3.
So what therapies would you consider discussing with Janice to manage her VMS based on current evidence and guideline recommendations? This is another one where you can choose all the answers that you think are correct, so it may be more than one. A, hormone therapy, such as estrogen. B, an SSRI, like paroxetine. C, an SNRI, like venlafaxine. D, an NK3 antagonist, like fezolinetant. I'm going to apologize ahead of time.
Fezolinetant. I practiced that one.
I practiced in my head. E, integrative medicine, like herbal
It's a challenge.
supplements.
That's why they make brand names we're not allowed to say. Okay, so people chose a lot of things for hormone therapy, and the NK3 antagonist is the predominant first choice. Okay, so let's talk about current VMS treatment use. So this is a retrospective observational cohort study of almost 300 healthcare providers prescribing data on about 1,000 women. And the most common prescription was hormone therapy. Much less common were compounded hormones, SSRIs, SNRIs, clonidine, gabapentin or pregabalin, SERMs, which are selective estrogen receptor modulators, and others. And in terms of non-prescription therapy, herbs, vitamins, these are very big categories, right? On the bottom, herbs, vitamins, supplements, traditional Chinese medicine therapy or therapies, not necessarily herbs, complementary and alternative therapy less so. And so behavioral and lifestyle interventions and the collection of other things were the most common, and that is up to more than 100. So I had to look at the study to see. So people are probably using more than one thing when using complementary and alternative medicine, whereas prescription therapy, there's usually a choice. Or people go through sequences. So that's a moment. This is obviously a moment in time. The Menopause Society, formerly the North American Menopause Society, and if you're not familiar with them, they have a wonderful website that has position statements and a number of guidelines for both physicians, nurse practitioners, for all allied health professionals. I don't know if they subdivide it, but they have really good professional information. And they also have a patient section, and they have things called Meno Notes, which are like handouts for patients. I really like this website. So I don't have a financial relationship to them. I just am suggesting it as a reliable source. The Menopause Society put out a position statement, the hormone position statement, and made the following point. And this is one of the key take-home points I'd like you to really gather in your brain. Hormone therapy remains the most effective treatment for vasomotor symptoms, VMS, and the genital urinary syndrome of menopause we talked about, and has been shown to prevent bone loss and fracture. The risk of hormone therapy differ depending on the type, dose, duration of use, route of administration, timing of initiation, and whether a progestin, any kind of progesterone, is used. Treatment should be individualized using the best available evidence to maximize benefit and minimize risk, with periodic reevaluation of the benefits and risks of continuing therapy. So many patients get like, we don't use hormones anymore, they're not safe, or we know it's not recommended anymore because they heard about the WHI. And that's just like not really the expert answer at this moment in time in science. This is really the better answer. It depends on the symptoms, on the patient, on their risk factors, whether we want to recommend or think about this as a treatment option with the benefits and risks presented. What are the indications? So we already talked about it being first line. It doesn't mean you have to use it, but it's FDA approved for moderate to severe VMS, prevents bone loss and premature estrogen loss, especially in women with early menopause. And it may help deal with genital urinary symptoms of the local estrogen therapy or other local hormonal therapy. Oral osipenafine serum is really preferred if you're just targeting vaginal symptoms, vulvovaginal symptoms and urinary symptoms, because you don't need systemic treatment. In patients with a uterus, unopposed estrogen therapy can result in endometrial hyperplasia and cancer. So you need to add some type of progestogen, and there's a number of different progestogens, including progesterone. That's why we use that term, to the estrogen. And there's a serum that combines basodoxifene to conjugate equine estrogen as an alternative to using progesterone. This is a very busy slide. I hopefully you'll be able to retain it or get a copy. I'm not sure if you get copies, but it shows kind of all the therapy options. In the interest of time, I'm not going to read each option. Take a moment and kind of stare at it as I speak, but I'm going to kind of guide you. So you can use an oral estrogen, and there are a number of choices. The most commonly used are conjugated equine estrogen and 17-beta estradiol. And you could use, or you can use it. So when you're using the estrogen, and it depends on if you have uterus, whether you need to use another form with it, another hormone, you can use a variety of types of transdermal estrogens in a patch, gel, or spray. Vaginal treatments are almost exclusively used when you're dealing only with genital urinary symptoms and their local delivery and low dose, minimally absorbed. There is one product that's systemic estrogen in the form of a ring, but it's the 17-beta estradiol ring, and that gives systemic levels. You can also use a SERM, which is a tissue-selective estrogen complex, and it combines oral conjugated equine estrogen with beta-doxyphene, which is a SERM. So that whole product, it's a single pill, is called a tissue-selective estrogen complex. So again, it combines an estrogen, an oral estrogen with a SERM. When you need to combine with a progestogen, for the reason I explained, there are a number of options. One is combining oral estrogen continuously with either oral progesterone or micronized progesterone, or a NETA, that's norethindrone acetate, or with drospiridone. And there, we can go into Q&A, we can go into the regimens if you want. You can give, that's if you give continuous. You can give oral intermittent with a combination pill. You can use transdermal continuous combined, but there you'd either be using a transdermal estradiol and an oral progestogen, or a levonorgestrel IUD, which is off-label but used commonly for this indication to protect the uterus from hyperplasia. Compounded hormone therapy in any way, shape, or form, according to society guidelines, including the Menopause Society, is not FDA approved or monitored and has potential safety and efficacy concerns. But sometimes that is utilized. You have to be careful about what you're doing, and we don't recommend it as part of this program. When you start hormone therapy, you have to consider a variety of issues. And this is a bit complex also, this slide, but I'll try to guide you through the key points. If they're less than 40 to 45, you want to get them to be like they would have been to the age of natural menopause to avoid those medical issues that I mentioned. And you want to continue treatment to get them up to those levels until the age of the average early range of natural menopause, which is age 50 to 51. So you can use a higher dose, like an estradiol patch 0.1, or oral 2 milligram estradiol with 200 milligrams of micronized progestin, or nightly 12 consecutive days, or low dose continued birth control pills, which you can also use. So you want to use a higher overall regimen. If they don't have a uterus, you just need estradiol. For example, if they had a surgery, the uterus taken out, and a bilateral also salpingo oophorectomy for one of the reasons that happens to premenopausal women as part of cancer prevention or cancer treatment. If they're in their late 40s and early 50s, and it's kind of a standard perimenopausal issue, you can use a lower dose patch where you're physiologically replacing them or supplementing them to give them relief of vasomotor symptoms and that fluctuation that causes that thermal regulation hypersensitivity in the kidney neurons. And you could give a milligram of estradiol with cyclic 200 milligrams nightly for 12 nights. So you can cycle them with a higher dose of progesterone, for example, or give continuous progestin with a steady dose of progestin. Those are two options. And if they have no uterus, just the estradiol. If they're older, late 50s to 60s with symptoms, you want to be a little more cautious about your estrogen dose to avoid like sort of over thrombotic effects. And transdermal, although it's not on this slide, there are some small trials, not the large RCTs like the Women's Health Initiative, to show that that might be less likely to affect oral to affect clotting factors, because it doesn't have first pass effect through the liver. But we still go with the lower doses to see if we can temper those symptoms. And we still need to use often continuous progestin is chosen. Now, one thing, and if they don't have a uterus, again, same low dose, but without the progestin. If you have questions about this, we can answer it a little later. I think one thing that is also not explicitly on the slide, but kind of implied by this slide, which is you want to think about the age of the patient, balance risk factor prevention, like in the very younger end of the menopausal spectrum, when they have an early menopause or primary ovarian failure. It's either induced or primary. Versus they're older and you want to be cautious, but you want to balance that with treatment of symptoms. You want to use the lowest dose that's needed for that person and for their situation. There are some warnings and contraindications, and warnings and contraindications are different, right? So you want to be cautious if the person doesn't have a preference for it. If they have established cardiodiabetes or migraines, but they're not absolutes. If they're over 60 or their onset of menopause was greater than 10 years ago, but they're coming to you with symptoms, you really have to have a risk-benefit conversation because the risks may go up in older women, and I'll show you a slide in a moment about that. If they have the things on the right that are a red hand, a stop sign, a contraindication, estrogen-dependent cancer, active VTE thrombophilia, unexplained vaginal bleeding, severe active liver disease, untreated, uncontrolled cardiovascular cerebrovascular disease. Those are in accordance with guidelines to be absolute contraindications for initiation. It gets tricky when they're on it, and that's kind of a nuanced, kind of specialized thing to think about, but often people think about really in these situations you really have to stop, and we often come up with alternative strategies. So this is also busy, but it summarizes the famous WHI and what it showed about benefit and risk. So I'll try to highlight in the top is the absolute risk of the number of events per 10,000 women. So there was an excess of events, 5 and 3 of DVT and PE in the people on estrogen alone, and everything else showed less than increased risk, so less likely. CHD, stroke, breast cancer, colorectal cancer, all cancers, all fractures, death from any cause, and diabetes. So this is like a modern myth that estrogen was bad for the women who didn't have a uterus, right? But if they are at risk for the two things that are on the right, you really have to think carefully about if they're candidates and how to manage them. However, if you look at the absolute risk per 100,000 women and women with progestin, it's a little bit different. This is the arm of the trial where women had to get both because they had a uterus, estrogen and progestin, and it was conjugated equine estrogen and medroxyprogesterone acetate. So there were 10 DVTs, 6 PEs for 10,000, 5 CHDs, 5 strokes, 6 breast cancer events. So these are relatively small numbers when they look at relative risk numbers. It was small increases, but they're noted and it's a consideration. But they were considered small numbers of events. Each of us has our own perspective when we look at per 10,000 events. Things, cancers, fractures, and death from any cause and diabetes were diminished by being on this combination. Those are small numbers, and if we break it down by age, some of this changes. Because remember, women in the WHI were initiated on therapy between the ages of not just 10 years after menopause, but 50 to the early 70s. 51. That's very different than starting sort of cardiovascular risk, for example. The tissue-selective estrogen compounds SERM, as I mentioned. And the advantage is it diminishes endometrial protection, doesn't increase bleeding, and there's this slight concern. It's not breast cancer with progestin. In fact, the small numbers in women who receive medroxyprogesterone acetate. So the theory with the beta-doxepin is that in fact it decreases breast density. It's not indicated as a breast cancer prevention drug, but it may decrease breast density, and something to keep in mind. And it does decrease vasomotor symptoms, bone mineral density, prevention of vulvovaginal atrophy. But what's not on the slide is because it has an oral estrogen and a SERM, the clotting risk is not diminished. You're still using an oral estrogen, and see in both types there was an increased risk of thrombophilia. So that it doesn't go away. This looks at the number of varying combinations of beta-doxepin and conjugated equine estrogen. Well, where is it? Sorry, it's the 20 of beta-doxepin estrogen of 0.45. It's hard to find an angle kind of in pretty low, good 10 is like most amount on the bottom of estrogen side of, and that's in terms of heart disease or VMS by age and duration of menopause. I really want you, which is this was all comers and starting at all ages, but if you break it down by age, when people policies published, total mortality last was actually relative risk of carded less than 60 or within 10 years of their final menstrual period. So there's this idea of like this window or this treatment time or this threshold when you start and you time where you actually benefit them. The idea is that if women age 60 years of age within 10 years of menopause without contraindications of excess cardiovascular or breast cancer risk, those women may benefit actually. They certainly won't be harmed from the standpoint of the data in terms of cardiovascular risk and mortality. So the Menopause Society has a new position statement, another one. This is 2023, and this looks at non-hormonal. I showed you the hormonal position statement earlier. But now I'm showing you the non-hormonal position statement and in general. They're good things for people, right? And there are good reasons to do these things. It's just not recommended as the answer to their disruptive or distressing vasomotor symptoms. So recommended or showing evidence includes cognitive behavioral therapy, weight loss, and stellate ganglion block, although that's very selective. You have to be pretty unhappy. I can't find something else to do that, but it is an option that has evidence. Not recommended is everything else, but I want to point out that it's actually good for sexual desire, mindfulness-based therapies. Respiration and cooling may actually make people feel better, although the number of VMS doesn't go down. Avoiding triggers is always good, right? Doesn't mean you shouldn't do that. And I'm very helpful in this time period, not specifically for vasomotor symptoms, but for other. Now, chiropractic, those things cost money. And if they're seeking out and you have to find a provider for this indication, you wouldn't recommend it necessarily. There's a lot of mishgas around soy. I'm sorry, I'm a New Yorker. There's a lot of does soy work. It's high protein, plant-based, low fat, but it doesn't seem to specifically, like eat soybeans, help specifically for the SSRIs, and they're listed here. You should be careful not to use these SSRIs with tamoxifen due to drug interactions or enzyme competition. Paroxetine salt is actually for VMS in a minute. SNRIs, including have shown benefit. Duloxetine is less than blood pressure with venlafaxine, but with both actually, but they're small. But if you notice, keep it in mind as a choice. Gabapentin, like neuropathic pain, migraine, sleep problems, because people can get daytime and morning sedation. I think it's under-recognized. I have a colleague who's on tamoxifen, swears by, does say that she gets dry out to be a good choice in those who have overactive bladder symptoms. Strangely, on its anticholinergic effects and anti. So this is a slide where I'm going to move a little bit. I have about 10 minutes for questions, I think. Low-dose paroxetine. This is the study that shows programs evaluated for vasomotor symptoms. The mean weekly approved with this treatment and approved in a statistical manner, and the side effects. And one thing about libido, orgasmic, or diminished orgasmic difficulty show in the studies. But I know it's not part of this lecture, but that's a consideration when you're using SSRIs in perimenopausal and postmenopausal women. There are some novel, I'll end with some practice saying them a few times, novel and emerging therapies. Fezolinetant was FDA approved since a little over a year ago, May of 2023. It is an NK3 antagonist, so it fights that KNDy neuron upregulation and hyperexcitability by blocking the NKB receptor on the KNDy neuron, working to modulate activity in the thermoregulatory center. So if you don't remember anything else, to remember, like, it blocks those upregulated, irritated KNDy neurons. And the dose is 45 milligrams daily at bedtime. Several doses were studied, but that was chosen as the efficacy and safety dose that was optimal. There's been, in phase 3, in investigational stages, phase 3 studies. In fact, just hot off the press, we changed the slides for this session, for this program, because let's get this one right. Ellen Xanatant is the next product in the same class. It's investigational. It's a dual NK1 activity in this whole center and may have enhanced value by blocking both the NKB and substance P on the reproductive axis, and that adds additional benefits. And its dose will be, hopefully, when it's approved, is 120 milligrams daily. And the phase 3 trials were just published. This is the Skylight trial. We'll end with these trials. The Skylight trial shows efficacy of fezolinetant for VMS in terms of ending the treatment, and then we'll talk finally about risk-benefit and conversations. The efficacy here, we can see of all the different doses, and the bottom line was that the 45 milligram dose was chosen, although 30 was close, and it showed improvements in vasomotor symptoms and severity at weeks 4 to week 12. It was a 12-week trial. Treatment emergent side effects, adverse events, included headache and blood glucose increase, were very minor amounts. And of any interest, LFT elevation, depression, and uterine bleeding had small numbers, but that is part of the contraindication. Women really tolerated this quite well. This is the Skylight trial, and it's another trial. In this trial, women took it for 4 to 12 weeks, and then there was an active extension phase, and it showed that the benefit was sustained in terms of frequency versus placebo. And there are some restrictions, as I mentioned, the liver enzymes. So you want to check prior to starting, and don't start if the LFTs are greater than 3 times the upper limit. And you should repeat it 3, 6, or 9 months, and counsel patients to report any symptoms that might show that they had liver damage. So cirrhosis and also severe renal impairment or end-stage kidney disease, as well as concomitant use of CYP1A2 inhibitors are considered contraindications. So it's the liver enzymes that you have renal dysfunction severe that you want to remember are the prime contraindications, as well as looking up their drug interactions. And that's, you don't have to remember what a CYP1A2 inhibitor is, of course, because we can't remember any of this, but it's something you want to pay attention to when you check drug interactions. This is the experimental trials that were just published, the OASIS 1 and 2, and it looked at the Xanatant efficacy, and it shows the average number of VMS symptoms, and so it's the frequency, and it shows the 2 trials, and you can see the mean change was, there was, in this trial, it's interesting, they did a placebo versus treatment trial in the treatment dose that I showed you, and then they had the placebo group cross over, and they did during the treatment phase, 14 to 26 weeks, I think, 12 to 26 weeks, and then there was follow-up where they separated them again, and when the placebo group got the treatment, they did the same as the treatment group, which was reinforcing the efficacy of the treatment. And this is, so this slide shows frequency, and this slide shows efficacy, and the graphs were similar in what happened when the placebo got treatment. And safety was also very well tolerated. The discontinuation rates were low, and the most frequently reported effects were headache, fatigue, and arthralgia, and the numbers were low compared to placebo. So let's do the post-test. I'm sorry, I'm running a little long, but I
Okay.
like doing this.
In which of these clinical scenarios would fezolinetant be the preferred treatment option for a patient in menopause with moderate VMS? A 55-year-old patient with CKD and a creatinine clearance of 25. B, 53-year-old patient with atrial fibrillation taking amiodarone. C, a 62-year-old patient with a family history of breast cancer. Or D, 65-year-old patient with treated HCV and cirrhosis.
Okay, so we got that answer, and answer C is correct for the reasons I think we all understand, that a family history of breast cancer doesn't preclude the use of fezolinetant, and it should be avoided in renal impairment, cirrhosis, and using CYP1E2 inhibitors. So check your drug interactions. So what are the key takeaways? Hormone therapy is highly effective for VMS. For women who are not good candidates for HT, whether because of clinical limitations or personal preference, there are several non-hormonal treatment options, including the FDA approved include the low-dose paroxetine, mesylate, salt, and fezolinetant, and in the pipeline is elinzanetant, and it looks like it has some enhanced receptor activity, and we'll see how it helps better or the same. The two were not compared head-to-head in terms of which to pick. It's another option. NK blocking agents have demonstrated efficacy with a reasonably short time to symptom relief, and they don't provide, though, the benefits on lipid, bone, or vaginal symptoms that we see with hormone therapy. So these are all considerations. We're going to finish with this section in terms of an individualized care, and I'll just highlight some key points. We have a few minutes for questions. Do you think, Janice wants to know, should I just wait it out? Maybe, and I hear this from a lot of patients. I don't know if you talk to patients. They're like, well, it's part of life. My grandmother did. Everyone does. And it's only the vasomotor symptoms that people are tolerating. And they're not thinking, do I want to have bone loss? Do I want to have cardiovascular? Like, how are they, some of the other things you can help them think more out loud? Will non-hormonal treatments be covered? What about prescription drugs? Some of the newer drugs, are they covered by my insurance? What is the safety? And I hear this often, I hear hormones aren't safe. That's what Newsweek and Time said 20 years ago. So isn't it true I shouldn't be taking it? My friends are all taking herbal supplements. Should I go to my Chinese practitioner or another herbalist? And will that help me? And so how should you approach this? Poll 4.
All right, what counseling strategies would be best to use in your discussion with Janice? Choose all that applies, so it could be more than one. A, convince her to try hormone therapy because it is not contraindicated. B, discredit information from non-medical sources. C, gather information about her preferences and goals. D, provide evidence of risks and benefits of treatments.
Okay, so we see provide evidence of benefit and risk
Good job.
and gather information, which all good. Okay, shared decision-making is a collaborative process. It engages and empowers the patient. It provides the patient information about alternatives and all treatments, and it incorporates patient preference and values into the plan, which is all, these are all good things. Shared decision-making, I like that abbreviation. I learned it a while ago. Caught me off guard at first. SDM is not the typical way healthcare professionals make decisions. Patients prefer this role, and it's really enhanced in the last couple of decades. Patients, 80% want patients to listen to them, but it doesn't happen. It happens like around less than 2/3 or so of the time. People want the full truth. The majority want to understand the risks also. They don't want to just tell, oh, take this is good for you. And they also don't, hormones are bad, just live with your symptoms. They want both. They want to know. And so it takes time and thoughtfulness, but learning how to distill it down into a few key messages. And it doesn't have to just be one appointment. So if someone brings it up at their annual exam, if you're in gynecology, or they're there for cardiovascular screening, reschedule an appointment specifically to talk about this. And, as a menopause visit, discuss menopause as a normal part of life. It isn't a disease, but people are distressed, and there's some issues around risk management and assessment that you want to consider. And education early on to watch and listen and let you know as things change, especially if you have a long-term relationship with a patient. Lots of patients this doesn't come up, and even when they have symptoms, it's not detected, as we talked about. Learning about the range of therapies and how to answer questions like, oh, herbs can be helpful, or no, don't use any, that's not, really learning a little bit more about the specifics of what might help with the thing that's bothering them. And we really want to look at health disparities. Because there's a lot of disparities around this. Some of it has to do with the way different ethnic and racial groups report things, and also their own comfort, and also provider comfort. You want to gauge and build rapport. You want to focus on what the patient wants to talk about, and be friendly, and don't be too sciencey, but also don't overgeneralize or trivialize. And really, you want to talk about advantages and disadvantages, as risks and benefits. Sometimes that's a little bit easier for people to hear. Wait, listen, use open-ended questions. I like the term the technique of ask, tell, ask. You ask a question about what they know, then you give tailored information, and then you ask for a reaction. It's a motivational interviewing strategy, and it allows you to gather what their knowledge base is and then respond. And then you can be collaborative of what's next and take it one step at a time. You want to be culturally sensitive, and there was differences in race and ethnicity about reporting vasomotor symptoms. Black individuals reported higher rates than Japanese women, and you can see the spectrum of where people fit in. Women deal with these symptoms differently. There may be differences in actual experiences or what they consider reportable. It's not to say anything in any direction. It's just there are variabilities, and being sensitive to what might be reported in different ethnic and racial groups is really addressing health disparities. So this is one race and prevalence of menopause. So some Black was like, I feel really stiff at night. Maybe that's how they're experiencing, or in their subgroup, how they talk about menopause. It's sort of hard to know how to make sense out of this, but maybe that's how the conversation goes, or maybe that's what they're actually feeling. So we want to bridge the gap. I'm sorry, I want to end this, and I want to kind of end with this. The treatment indication for vasomotor symptoms involves conducting a baseline health assessment. So if they're less than 60 or less than 10 years out of menopause, you want to consider hormone therapy as an option, the formulation, the dose, and the route. Look at how the benefit might outweigh the risk in that patient, and initiate, but reassess annually to see if it's still needed based on symptoms and preference. If they're less than 60 or less than 10 years, but they have contraindications, you want to move to approach similar to patients greater than 60 or more than 10 years from onset, and consider either non-hormonal prescription or approaches, and if the land there. You want to monitor dose adjustment therapies based and be assessment for osteoporosis, including mammograms, and really assess any additional health concerns. I think we should end here. We were a little, a lot to say. I'm sorry we didn't, but we can go on first of all.
50 women with onset of present MS. How would you counsel her based on treatment? Based on her age, pause, treatment's not indicated. Hormonal therapy only. C, she is a candidate for non-hormonal therapy only. Or D, she is a candidate for either hormonal or non-hormonal.
Okay. Okay, so I think we all understood this person based on the algorithm I showed toward the end. And yes, in fact, whoops. Because of her age and her lack of comorbidities.
Good job. We have a few questions. I can kind of combine some of them.
Yes,
So
we
I
can
think,
do that.
yeah, you
Thank
talked
you.
a lot about in primary care, the risk of menopause overall to women and how hormonal or non-hormonal can help with that. So do you think that primary care providers should proactively screen for vasomotor symptoms and other symptoms of menopause to be like a preventative?
Yeah, so I think that's a great question. It's sort of built into the point I was making, is to start education early. So I think asking and educating go hand in hand, right?
Yeah.
So in the late 30s, I start to ask, it's a good time to start asking, not necessarily you're having hot flashes, but like what's happening with your reproductive situation, what's happening with your menses. Let's talk about that annually. And then as you get into the mid to late 40s, beginning to screen for the main things are menstrual changes and vasomotor symptoms.
Mm-hmm.
And then thinking if they're young and they're starting to have symptoms about cardiovascular issues, et cetera.
Yeah, another question came in about those folks with vasomotor symptoms that are maybe less than that age 45. They don't want to take hormones and you try the non-hormonal approach. How long should you see efficacy? And if you don't, should you then continue to counsel them about maybe trying hormones?
I mean, with the pharmaceuticals, the trials were, efficacy was seen at 4 to 12 weeks, depending on the agent. So if you're not, I kind of always have